A patient's heart flatlined during emergency surgery. The head surgeon was still en route to the hospital. The operating room descended into pandemonium with junior physicians debating frantically. Medical tools lay scattered across surfaces. A petite female nurse maintained a low profile. Everyone ignored her presence as she calmly moved forward. Her hands shook slightly, yet she grasped the torn artery with precision. The monitoring device resumed its rhythmic beeping. The patient's heart began pumping once more. The doors flew open as the chief surgeon hurried inside, then stopped dead in the tense atmosphere. The chief surgeon could only murmur, "This woman transcends the role of mere nurse." Emily Carter had lived 28 years. She was an American healthcare worker with a small frame. Her lengthy brown hair was secured in a tidy arrangement. Soft blue eyes complemented her kind features. Emily had recently begun working at this major medical facility. Physicians frequently overlooked her as simply another new nursing staff member. Throughout her work periods, whenever she recommended preparing extra medical tools, doctors would dismiss her suggestions. "That falls under physician responsibilities, you simply provide assistance," they would say. Several resident doctors referred to her privately as the shadow nurse, someone who merely remains quietly in the periphery. During a nighttime emergency operation, a patient arrived with aortic rupture. Blood flowed at an alarming rate while young doctors disputed among themselves. Contradictory commands filled the air as instruments clattered to the floor. No one maintained authority over the situation. Emily positioned herself in the corner, keeping her gaze downward in silence. One physician snapped irritably, "Don't simply observe, follow instructions." Emily had been employed at Metropolitan General Hospital for 90 days. The adjustment from military duty to civilian medical care had proven more difficult than she had expected. The hospital's power structure was inflexible and harsh. Nursing staff were required to obey commands without inquiry, to provide help without voicing opinions, to stay unnoticed unless specifically summoned. This presented challenges for someone who had spent years making critical decisions independently. Emily's co-workers perceived her as reserved, possibly even shy. She seldom contributed during shift meetings, never questioned attending physicians' choices, and appeared satisfied handling routine responsibilities without objection. Dr. Matthews, among the senior residents, had expressed the prevailing view. "Carter demonstrates adequate competency, but she lacks the self-assurance for anything beyond fundamental nursing responsibilities." However, Emily's seeming passivity didn't stem from insufficient confidence. It represented a deliberate decision to prevent attracting notice to abilities that might prompt awkward inquiries about her history. During her initial week, Emily had observed multiple occasions where medical procedures could have been enhanced through improved preparation or different approaches. Yet she had learned to keep such observations private. The new nurse believed she surpasses the doctors in knowledge. She had overheard Dr. Rodriguez's comment after she had quietly recommended repositioning a patient for better surgical access. Consequently, Emily had adjusted her approach. She executed her designated responsibilities perfectly, anticipated requirements without prompting, and remained professionally invisible. Nevertheless, her military conditioning never completely deactivated. Emily automatically performed situational awareness evaluations in every room she visited. She mentally recorded emergency equipment locations, or observed personnel stress indicators, and continuously assessed potential complications. These behaviors had become so deeply embedded that she executed them unconsciously, like natural breathing. This evening's emergency surgery exemplified institutional breakdown under pressure. The patient, a 43-year-old construction worker, had been brought in with severe internal bleeding from a work-related incident. The attending surgeon, Dr. Harrison, remained trapped in traffic after receiving the emergency call at home. The resident physicians on duty possessed skill but lacked experience with this severity of trauma. Emily had examined the patient during admission and immediately identified the gravity of his condition. Based on his vital signs and symptom presentation, she recognized they were confronting a ruptured abdominal aorta, a condition that claimed patients' lives within minutes without immediate action. She had prepared the operating room according to standard procedures, but had also quietly assembled additional equipment not included on the typical surgical tray. Emergency circumstances frequently demanded improvisation, and proper preparation could determine whether someone lived or died. When she had suggested these extra preparations to Dr. Kim, the lead resident, she faced dismissal. "Carter, focus on your expertise. "We'll manage the medical choices," he had said. Emily had prepared the supplementary equipment regardless, positioning it within reach but concealed from view. A nurse who witnessed these events later remembered, Emily's eyes seemed different that evening, not frightened, but as though she anticipated the proper moment. "I'll never forget that expression." Now, as the situation rapidly deteriorated before her, Emily confronted a decision that would determine not only this patient's survival but also her own future at the hospital. She could adhere to protocol, remain quiet, and watch someone die, or she could take action. The patient's heart ceased beating. Blood poured continuously as monitor screamed. The lead doctor's hands trembled while reaching for incorrect clamps. Someone else yelled, "We're going to lose the patient." Emily clenched her fists, then rushed forward without seeking permission. She used her bare hands to precisely compress the bleeding artery. The bleeding ceased, and monitor alarms stopped. Complete silence filled the room. A young doctor whispered, "How did she identify the exact position?" Emily calmly issued directions, "Suture immediately, I cannot maintain this hold much longer." The surgical team hesitated initially but then followed her guidance. Within minutes, bleeding was controlled and the patient's heart resumed beating. At precisely that moment, the chief surgeon entered. He stood motionless, observing Emily kneeling beneath the lights with blood-covered hands. Having preserved the patient's life, the crisis had escalated more rapidly than anyone had anticipated. What began as standard emergency surgery had transformed into a life-or-death situation that surpassed the resident physician's training and expertise. Dr. Kim had been attempting to locate the internal bleeding source when the patient experienced cardiac arrest. The combination of massive blood loss and surgical stress had overwhelmed the man's cardiovascular system. "Code Blue, we need the crash cart," Dr. Rodriguez had shouted. However, the cardiac arrest was secondary to hemorrhaging. Until they stopped the bleeding, no amount of cardiac resuscitation would save the patient. Emily had observed the chaos developing with increasing urgency. She could perceive what the doctors missed or were too stressed to recognize. The bleeding wasn't originating from the obvious surgical site. Based on blood flow patterns and the patient's position, the rupture was approximately 3 centimeters interior to where Dr. Kim applied pressure. In Afghanistan, Emily had learned to make such assessments instantly. When medics reached casualty sites, they often had seconds to identify injury patterns and prioritize interventions. This patient was bleeding from his abdominal aorta and the resident fissure. Emily's military training activated automatically. She had performed this exact procedure numerous times under combat conditions, not in sterile operating rooms with proper equipment, but in desert outposts while under enemy fire with improvised tools and no backup. "Excuse me," she said quietly, moving toward the patient. "Carter, stay back," Dr. Kim commanded. "We need space to work." But Emily no longer followed civilian hospital protocol. She operated under medical battlefield doctrine that had kept dozens of soldiers alive. She pushed past Dr. Rodriguez and placed her hands directly on the patient's abdomen, feeling for arterial disruption through the surgical incision. "What are you doing?" Dr. Kim demanded. "Saving his life," Emily replied, her voice completely calm. Her fingers located the tear in the aortic wall immediately. Years of battlefield experience had taught her to identify internal bleeding through tactile examination when visual assessment was impossible. She applied direct pressure to the arterial wall, using her thumb and index finger to compress the vessel against the posterior abdominal wall. The bleeding stopped immediately. The room fell silent except for monitoring equipment returning to normal ranges. Dr. Kim stared at Emily in disbelief. Where did you learn to do that?" Emily maintained pressure on the artery while speaking, "This needs suturing within the next few minutes. I can't maintain compression much longer." Her matter-of-fact tone galvanized the surgical team. Dr. Rodriguez began preparing sutures while Dr. Kim positioned retractors to provide better access to Emily's hand placement. "Guide me," Dr. Kim said, his earlier dismissive attitude completely gone. "Show me exactly where to place the sutures." Emily directed the repair with clinical precision, indicating optimal suture placement angle and recommending specific techniques for managing arterial wall tension. 2 mm bites, interrupted pattern. Start proximal and work distally to avoid compromising the repair. Her instructions were specific, technical, and delivered with the confidence of someone who had performed similar procedures numerous times. Within 12 minutes, the arterial repair was complete, the patient's vital signs stabilized, and his cardiac rhythm returned to normal. Dr. Kim stepped back from the table, staring at Emily with a mixture of admiration and confusion. "Carter, where did you learn vascular surgery techniques?" Emily was cleaning her hands methodically, her movements calm and professional. "I've had some experience with trauma medicine." "What kind of experience?" Before Emily could answer, the doors burst open and Dr. Harrison, the attending surgeon, rushed into the room. He had expected to find either a successful surgery in progress or a patient who had died during the delay. Instead, he found a completed vascular repair and a stable patient. "What happened here?" Dr. Harrison demanded, looking around the room. Dr. Kim gestured toward Emily. "The nurse saved the patient. Performed arterial compression and guided the entire repair." Dr. Harrison studied Emily's face, noting her calm demeanor and the blood on her scrubs. "Nurse Carter, I'd like to speak with you after we close." Emily nodded without speaking. A resident doctor later testified, "In that moment, we followed her orders without question. It seemed like she had done this many times before." As the surgical team completed the procedure, Emily quietly resumed her normal duties, cleaning instruments and preparing the OR for the next case. But everyone in that room knew they had just witnessed something extraordinary, and Dr. Harrison was determined to find out exactly what after the surgery. News spread quickly throughout the hospital. Nurse Emily saved the surgery instead of the doctors. An older doctor checked her file, discovering Emily had been a combat medic in the Navy, having served in Afghanistan. During one battle, Emily had saved 6 Special Forces soldiers when there were no instruments, using only her bare hands to stop arterial bleeding after discharge. She studied nursing, wanting to continue healing but hiding her past to live peacefully. The surgical team was stunned. The person they had dismissed all along was someone who had saved many soldiers' lives on the battlefield. Emily didn't tell stories or brag. She only said, "I just did what I used to do before." Dr. Harrison's investigation into Emily's background had been prompted by professional curiosity rather than suspicion. What he discovered changed his entire understanding of the quiet nurse who had been working in his hospital for 3 months. Emily's personnel file contained only basic information: nursing degree from a state university, references from previous employers, standard certifications. But there were gaps in her employment history that suggested military service. A phone call to the Veterans Administration confirmed Dr. Harrison's suspicions. Emily Carter had served as a hospital corpsman with the U.S. Navy for 6 years, including 3 deployments to Afghanistan as part of a forward surgical team attached to Special Operations Units. Her service record, though partly classified, revealed extraordinary circumstances. She was awarded the Navy and Marine Corps Commendation Medal for Valor. The VA representative had told Dr. Harrison something about saving multiple lives under enemy fire, but the full story was even more remarkable. During her second deployment, Emily's forward surgical team had been providing medical support for a classified operation in Helmand province when their position came under attack by Taliban forces. The team's surgeon had been killed in the initial assault, leaving Emily and 2 other MED CS to treat multiple casualties without senior medical supervision over the course of 6 hours. While under intermittent enemy fire, Emily had performed procedures that exceeded her official training level. She conducted emergency thoracotomies, repaired arterial damage, and managed complex trauma cases that would challenge experienced surgeons. 6 special operations personnel had survived injuries that should have been fatal, entirely due to Emily's improvised medical interventions. She basically performed field surgery with minimal equipment, the VA representative had explained. Saved lives that conventional wisdom said couldn't be saved. But Emily's heroism had come at a personal cost. During the same engagement, she had been forced to make triage decisions that haunted her afterward. With limited resources and multiple casualties, she had to prioritize some patients over others. Not everyone had survived. Emily's post-deployment psychological evaluation had noted symptoms consistent with moral injury, the psychological damage that occurs when individuals are forced to take actions that violate their personal values, even when those actions are necessary and justified. Subject demonstrates exceptional technical competence but expresses guilt over casualty decisions made during combat operations, the evaluation had noted when Dr. Harrison finally confronted Emily with his findings. She was restocking supplies in the cardiac surgery unit. "Emily, could we speak privately?" They walked to Dr. Harrison's office, where he had prepared copies of her military commendations and service records. "I know about Afghanistan," he said directly. Emily's expression didn't change, but Dr. Harrison could see resignation in her eyes. "I figured someone would eventually find out. Why didn't you tell us about your background when you applied here?" Emily sat quietly for several moments before answering. "Because I wanted to be just a nurse. Not a war hero, not someone with a special story. Just someone who takes care of patients and goes home at the end." Oh. Dr. Harrison understood. Many veterans struggled with the transition from military service to civilian careers, especially those who had served in combat roles. "Emily, the procedures you performed tonight, those weren't basic nursing interventions." "No, they weren't. You saved that man's life using techniques that most surgical residents haven't mastered." Emily looked directly at Dr. Harrison. "Sir, I've seen what happens when people die because medical help arrives too late or when equipment isn't available. I've performed surgery in conditions that would terrify most surgeons. And you've been hiding that experience for 3 months." "I wasn't hiding it, I just wasn't advertising it." Dr. Harrison reviewed Emily's commendations again. The citations were remarkable, multiple instances of exceptional medical care provided under conditions that would have paralyzed most healthcare professionals. "Emily, why nursing? With your experience, you could have applied to medical school, become a surgeon yourself." Emily's answer revealed the depth of her character, because nurses spent more time with patients. Surgeons save lives in operating rooms, but nurses take care of people while they heal. "After what I saw in Afghanistan, taking care of people seemed more important than cutting into them." The distinction was meaningful to Emily in ways that Dr. Harrison was only beginning to understand. "The 6 soldiers you saved, do you stay in touch with any of them?" 3 of them, Emily replied. "They sent me pictures of their kids sometimes." This simple statement revealed more about Emily's motivation than any military citation could convey. She had chosen nursing not because she couldn't do more, but because she wanted to do something different, something that felt more like healing than fighting. "Emily, I want to offer you an opportunity. We're starting a trauma surgery training program for nurses, advanced procedures, emergency interventions. Your experience would be invaluable." Emily considered the offer. "Would it mean more attention? More questions about my background?" "It would mean recognition for capabilities you've already demonstrated. And it would mean better outcomes for patients who arrive here in critical condition." Emily thought about the construction worker from tonight's surgery. He would go home to his family because she had been able to intervene when conventional protocols weren't sufficient. "Can I think about it?" "Of course. But Emily, I want you to know what you did tonight reminded everyone in that or why we became medical professionals in the first place, to save lives when it matters most." As Emily left Dr. Harrison's office, she realized that her carefully maintained anonymity had ended. But perhaps that wasn't entirely a bad thing. Maybe it was time to use her experience to help others instead of hiding from it. From that day forward, the doctors changed their attitudes. No one dismissed Emily's suggestions anymore. Many even consulted her opinion before surgeries. But Emily didn't change her way of living, still quietly cleaning up, preparing instruments, greeting patients with small smiles. A young doctor approached her. "Apologizing, we were wrong to look down on you." Emily just smiled. "Don't apologize to me. Respect every nurse, because one day they might save your life." The chief surgeon, who had stood frozen that day, later called Emily the silent medic, a symbol of quiet strength. Word of Emily's background spread throughout Metropolitan General within a week. The story had been impossible to contain. Too many people had witnessed the emergency surgery, and the outcome had been too dramatic to ignore. But the attention came with unexpected consequences. Dr. Matthews, who had previously dismissed Emily as lacking confidence, approached her during a morning shift change. "Carter, I owe you an apology. I misjudged you completely. Emily was checking inventory on the crash cart, a routine task she performed at the start of every shift. Dr. Matthews, you evaluated me based on the information you had available. That's not your fault. But I should have recognized confidence when I saw ET. Emily stopped her work and looked at him directly. Doctor, competence doesn't always look the same. Some people are quiet not because they don't know what they're doing, but because they're focused on doing it right. This conversation was repeated dozens of times over the following days as medical staff throughout the hospital reassessed their assumptions about the quiet nurse who had worked among them unnoticed. Nurse manager Patricia Webb called Emily into her office to discuss the situation. Emily, Dr. Harrison has recommended you for our advanced trauma nursing program. It would mean additional training, higher salary, more responsibility. What would it mean for my day-to-day work? You'd be assigned to our highest acuity cases, emergency surgeries, critical patients, situations where your experience would make the biggest difference. Emily considered this carefully. The program would provide official recognition for skills she had developed through military service, but it would also mean increased visibility and attention. Would I still work with regular patients, not just trauma cases? Of course. Why? Because everyone deserves good care, not just the dramatic cases. Webb smiled. That's exactly the attitude we want in our advanced practitioners. Emily's decision to accept the position surprised no one who had worked closely with her. She had never sought attention, but she had never avoided responsibility. Either the construction worker whose life she had saved, James Rodriguez, returned to the hospital 2 weeks later for a follow-up appointment. When he learned about Emily's role in his survival, he insisted on meeting her personally. You saved my life, he said simply. My kids still have their dad because of you. Emily's response was characteristic. Mr. Rodriguez, the entire surgical team saved your life. I just did my part. The doctors told me what really happened. You did more than your part. Emily smiled. That's what we do here, whatever it takes to help people get better. The interaction reminded Emily why she had chosen nursing over other career paths available to her. Direct patient contact, personal connections, the opportunity to impact individual lives, these aspects of healthcare meant more to her than professional recognition or career advancement. 3 months after the emergency surgery, Emily had settled into her new role as a senior trauma nurse. She worked primarily night shifts, handling the most complex cases that arrived during off-peak hours. But she also volunteered for community health programs, providing basic medical care to underserved populations in the city. Her military experience had taught her that healthcare was most meaningful when it reached people who needed it most. Dr. Harrison observed Emily's development with professional satisfaction. She's exactly what we needed, he told Webb during a staff meeting. Someone with exceptional skills who uses them to elevate everyone around her. If you believe that silence can hide true strength, type respect in the comments. Emily Carter had found a way to serve that honored both her military experience and her desire for peaceful civilian life. She remained quiet, competent, and dedicated to patient care, but now her colleagues understood that her quietness reflected focus. Rather than timidity, the silent medic had taught an entire hospital about the importance of looking beyond surface appearances to recognize the capabilities that exist in unexpected places. Dr. Matthews, who had previously dismissed Emily as lacking confidence, approached her during a morning shift change. Carter, I owe you an apology. I misjudged you completely. Emily was checking inventory on the crash cart, a routine task she performed at the start of every shift. Dr. Matthews, you evaluated me based on the information you had available. That's not your fault. But I should have recognized confidence when I saw ET. Emily stopped her work and looked at him directly. Doctor, competence doesn't always look the same. Some people are quiet not because they don't know what they're doing, but because they're focused on doing it right. This conversation was repeated dozens of times over the following days as medical staff throughout the hospital reassessed their assumptions about the quiet nurse who had worked among them unnoticed. Nurse manager Patricia Webb called Emily into her office to discuss the situation. Emily, Dr. Harrison has recommended you for our advanced trauma nursing program. It would mean additional training, higher salary, more responsibility. What would it mean for my day-to-day work? You'd be assigned to our highest acuity cases, emergency surgeries, critical patients, situations where your experience would make the biggest difference. Emily considered this carefully. The program would provide official recognition for skills she had developed through military service, but it would also mean increased visibility and attention. Would I still work with regular patients, not just trauma cases? Of course. Why? Because everyone deserves good care, not just the dramatic cases. Webb smiled. That's exactly the attitude we want in our advanced practitioners. Emily's decision to accept the position surprised no one who had worked closely with her. She had never sought attention, but she had never avoided responsibility. Either the construction worker whose life she had saved, James Rodriguez, returned to the hospital 2 weeks later for a follow-up appointment. When he learned about Emily's role in his survival, he insisted on meeting her personally. "You saved my life," he said simply. "My kids still have their dad because of you." Emily's response was characteristic. "Mr. Rodriguez, the entire surgical team saved your life. I just did my part. The doctors told me what really happened." "You did more than your part." Emily smiled. "That's what we do here, whatever it takes to help people get better." The interaction reminded Emily why she had chosen nursing over other career paths available to her. Direct patient contact, personal connections, the opportunity to impact individual lives, these aspects of healthcare meant more to her than professional recognition or career advancement. 3 months after the emergency surgery, Emily had settled into her new role as a senior trauma nurse. She worked primarily night shifts, handling the most complex cases that arrived during off-peak hours. But she also volunteered for community health programs, providing basic medical care to underserved populations in the city. Her military experience had taught her that healthcare was most meaningful when it reached people who needed it most. Dr. Harrison observed Emily's development with professional satisfaction. "She's exactly what we needed," he told Webb during a staff meeting. "Someone with exceptional skills who uses them to elevate everyone around her." If you believe that silence can hide true strength, type respect in the comments. Emily Carter had found a way to serve that honored both her military experience and her desire for peaceful civilian life. She remained quiet, competent, and dedicated to patient care, but now her colleagues understood that her quietness reflected focus. Rather than timidity, the silent medic had taught an entire hospital about the importance of looking beyond surface appearances to recognize the capabilities that exist in unexpected places.